The human heart relies on a strict four-chamber division of labor. Blood enters through the two collecting chambers up top, the atria, before being pumped down into the two main driving chambers, the ventricles. Separating the right and left sides is the septum, a solid muscular wall designed to keep the two halves of the system completely isolated from one another. Look at this simplified schematic of the heart. When a structural gap remains in the lower portion of this wall, the ventricular septum, we call it a ventricular septal defect, or VSD. Among infants, this specific opening is the single most common congenital heart defect worldwide. Yet, while it is frequently diagnosed in babies, it is relatively rare to find in adults. That discrepancy exists because between 30 and 50% of all VSDs close on their own during childhood, as the tissue naturally grows and seals the gap. When the defect does not close spontaneously, the clinical outcomes vary drastically, ranging from a faint murmur picked up by a stethoscope to severe oxygen deprivation across the entire body. To understand how a static hole leads to such dynamic clinical failure, we have to look past the cardiac muscle itself and analyze the heart as a pressurized fluid system. By tracing the origins of this gap back to fetal development, we can map the physical forces it disrupts and see exactly how localized damage cascades into systemic collapse. Long before birth, the developing heart is just a single, unpartitioned tube. This cross-section shows the first step in separating the ventricles. A thick ridge of muscle grows steadily upward from the bottom apex of the heart. Simultaneously, a separate, much thinner layer of membranous tissue descends from the upper endocardial cushions. In normal development, these two distinct structures meet in the middle and completely fuse to create a watertight seal between the two chambers. But if the growth of either tissue stalls, they stop short of contact, leaving a permanent gap between the two sides. The vast majority of these defects trace back to a specific failure within that descending, thinner membranous section of the septum. These precise developmental missteps frequently coincide with other systemic conditions. Infants exposed to alcohol during gestation face a higher risk, linking VSDs directly to fetal alcohol syndrome. The defect is also highly correlated with Down syndrome, frequently presenting alongside a cluster of other structural cardiac abnormalities. A macroscopic physical problem thus begins as a microscopic error in tissue timing, an error that leaves the heart ill-equipped to handle the intense physical forces of a functioning circulatory system. Consider the pressure gradients in a healthy heart. As shown in this model, the resting pressure on the left side is substantially higher than on the right. The left ventricle must generate enough force to propel blood all the way down to the toes and back, while the right ventricle only needs a gentle push to reach the adjacent lungs. Deoxygenated blood drops into the right atrium, fills the right ventricle, and is pumped out to the lungs to gather oxygen. That freshly oxygenated blood then returns to the left side, filling the high-pressure left ventricle. When a septal defect is present, that pressurized blood suddenly has two possible exit routes. Instead of forcing all its volume against the massive resistance of the systemic arteries, a portion of the oxygenated blood takes the path of least resistance, shooting across the gap into the low-pressure right ventricle. Clinicians define this abnormal rerouting as a left-to-right shunt. Because oxygen-rich blood is mixing back into the deoxygenated side, diagnostic tools will register abnormally high oxygen saturation levels inside the right ventricle and the pulmonary artery. The turbulent physical force of that fluid forcing its way through the defect produces a distinct sound, a hollow systolic murmur audible at the lower left border of the sternum. At this stage, the body is still receiving oxygen, but the heart is wasting enormous energy recycling clean blood back through the lungs in a continuous loop. If the defect is small enough, this inefficiency goes entirely unnoticed and patients remain asymptomatic. But as the size of the gap increases, the sheer volume of blood shifting from left to right becomes an immediate structural threat. Watch what happens to the right ventricle as it receives a double payload of blood. The muscular walls distend outward to accommodate the excess fluid volume. To protect the delicate capillaries of the lungs from this continuous flood, the vessels of the pulmonary artery adapt by thickening their own walls, heavily restricting the available pathway. Forcing the same massive volume of fluid through a suddenly narrower pipe dramatically drives up resistance, requiring higher and higher pressure to maintain flow. This escalating backup of force within the right-sided circulation is diagnosed as pulmonary hypertension. In its attempt to shield the lungs from drowning in fluid, the vascular system inadvertently creates a deadly buildup of internal pressure. This rising pressure on the right side of the heart steadily approaches a critical mechanical threshold, one that dictates the patient's survival. Eventually, pressure required to pump against those hardened pulmonary vessels matches and violently surpasses the systemic pressure on the left side. The moment the pressure gradient inverts, fluid dynamics flip. The direction of flow reverses, blasting deoxygenated blood straight into the oxygen-rich left ventricle. This terminal right-to-left pressure reversal is clinically defined as Eisenmenger syndrome. The lungs are now functionally bypassed. Blood returning from the body simply skirts the pulmonary system entirely. Instead, raw, unoxygenated blood is loaded into the left ventricle and fired directly into the aorta. The inverted pressure gradient transforms a localized volume problem into a massive systemic oxygen crisis. With deoxygenated blood circulating through the systemic arteries, peripheral tissues experience a drastic reduction in oxygen delivery. This widespread oxygen deprivation becomes visibly apparent on the skin as cyanosis. The bluish discoloration reveals itself first in highly vascular areas, turning the lips and the fingertips a distinct pale blue. Look at the complete clinical progression. A structural defect creates a left-to-right shunt. The resulting volume overload induces pulmonary hypertension, which eventually inverts the pressure gradient into a right-to-left shunt, culminating in systemic cyanosis. Because the vascular hardening that drives Eisenmenger syndrome is often irreversible, medical intervention must intercept the disease long before the pressure inverts. Surgical closure of a ventricular septal defect is required to permanently safeguard the heart's delicate pressure gradients from ultimate collapse.